The road to innovation is long. It takes passion and expertise, craftsmanship and collaboration. But most importantly, it takes drive. The drive to improve clinical and operational outcomes with smart imaging technologies that leverage the latest AI innovations and push the boundaries of high-resolution image quality. At Canon Medical, we are committed to innovating, with your success in mind. No matter how far the journey takes us, we are here to help you and your patients get the best treatment, clinical and business outcomes possible. Outcomes-driven innovation, made possible by Canon Medical. Made for life.
The technical efficacy of a gadolinium-based contrast agent depends on its relaxivity. That is, by how much T1 relaxation time is shortened. For efficient relaxation, water molecules need to bind directly to the inner coordination sphere of the gadolinium ion. By getting close to the gadolinium, each water molecule relaxes and then exchanges rapidly with the next water molecule. The molecular structure of the GBCA determines how effectively this happens. The macrocyclic GBCA Gadovist has a special molecular structure with 3 hydroxyl groups. Those 3 hydroxyl groups retain water molecules through hydrogen bonding to build a large hydration sphere around the gadolinium, which is also called the second sphere. Now, not only do the water molecules in the inner sphere relax, the water molecules in the second sphere are close enough to the gadolinium ion to relax as well. The ability of Gadovist to support both inner sphere and second sphere interaction with water molecules results in high relaxivity, leading to an enhanced signal intensity on the MR image. With its special molecular structure, Gadovist shortens T1 relaxation time more efficiently than other macrocyclic contrast agents, which could enhance image quality and improve diagnostic confidence.
Are you looking for a system that makes it fast and easy to ramp up productivity and deliver exceptional quality images? Discover Philips MR5300. It takes our revolutionary helium-free MR operations to the next level. With AI-driven breakthroughs designed to automate the most complex tasks so you can focus on your patients. Smart workflow combined with our lightest and most versatile breeze coils reduces the number of steps needed to complete an MR exam. You can set up patients in under a minute and accelerate change over time by up to 30%, while the MR5300's innovative Comfort Plus mattress simplifies cable handling. Compressed Sense speeds MR scans by up to 50% with virtually equal image quality. With MR5300, it is possible to scan routine exams like the brain and knee in just 5 minutes, freeing up time slots for additional patients. You can count on high-quality clinical images thanks to the new versatile Breeze coils and robust scanning methods, even when imaging the most challenging anatomies and the smallest joints. And to lower the total cost of ownership, our service solutions assure performance for life. Make the smart choice with Philips MR5300.
perception, understanding, reasoning, creativity, wisdom, learning, intelligence. The ability to think abstractly and rationally and use that thought for purposeful action, the strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of Somatome Excite. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
疗界同仁大家好，欢迎参加2022年第22届澳门放射师学会学术年会。受2019新型冠状病毒的肺炎影响，本次年会以网络会议的形式进行。
Ladies and gentlemen, welcome to 2022, the 22nd Annual Scientific Meeting of the Macau Radiological Technologists Association. Due to the impact of COVID-19, this meeting is being conducted via live internet broadcast. According to our schedule, we will now play the national anthem.
本次学术年会是由澳门放射师学会主办，同时为第19次亚洲放射师持续专业发展课程以及粤港澳大湾区放射师学术论坛。今年大会的主题是乳腺影像学。
This year's scientific meeting is being held by the Macau Radiological Technologists Association and is also the 19th online continuing professional development platform for Asian Radiologic Technologists Societies in conjunction with the Radiological Technologists Forum of Guangdong, Hong Kong, Macau, Greater Bay Area with the theme Breast Imaging.
It's our honor this year to have panelists from around the world. Please say hello to our audience when I announce your name. First, let me introduce Mr. Dennis Eugene Chun from the MRTA. Hello, Mr. Yu. And then we have Miss Sophia Lee from Cambodia. Hello. Miss Junhui Zhang from Guangdong, China. Hello. Mr. Kang Zhuang from the Guangdong Medical Association Imaging Technology Branch, China. Mr. Nelson Wen from Hong Kong. Mr. Apollo Wong from Hong Kong. Mr. Selva Kumar from the ISRT, India. Hello. Mr. G. Sugianto from Indonesia. Miss Chan A. Kwan from Malaysia. Hello, Miss Chan.
Hello.
Mr. Tumi Berkach from Mongolia. Hello. Miss Yin Yin Fan from Myanmar.
Hello.
Miss Yimei O from Myanmar.
Hello.
Mr. Rolando Benares from the Philippines. Hello. Miss Denise Zhong from Singapore. Hello, Miss Denise.
Hello.
Mr. Chunyuan Chu from Taiwan. Hello, Mr. Chu.
Hello.
And Mr. Taiwan Lok from Vietnam, VALT. Hello, Mr. Lok. Hello, Mr.
Hello,
Lok.
everybody. Yeah. Hello everybody. Sorry, host, open my camera, please.
Hold on. Okay, hello. We also have Miss Pichi Luna, the General Secretary of ASIA CPD.
Hello, everyone.
Okay, last but not least, we have Mr. Fernando Kuok from the MRTA. Hello, could you say hello to all?
Hello everyone. Good morning. Distinguished guests, friends, ladies and gentlemen, welcome. On the behalf of the Macau Radiological Technologists Association, I would like to express my warmest greetings to all friends and colleagues from different countries and regions, and welcome to the 22nd Annual Scientific Meeting, as well as the 19th ASIA CPD. The theme of this year is breast imaging. Speakers from Great Bay Area. Great Bay Area we know is Guangdong, Hong Kong, and Macau. The online ASIA CPD platform was established in September 2020, that's about 2 years ago, and was co-founded by 5 societies in Asia. It's aimed not only to create a free online learning platform for RTs in Asia, but to enable the RTs from the different countries and the region to share the latest technology and valuable experience gained with each other. The ASIA CPD platform, in 2 years, total we have 11 RT societies have joined it, with increasing numbers of participants in each CPD program, like today more than 1,000. So we look forward to the futures, and I hope this platform will continue to grow and continue to improve the skills and the standards of radiological technologies from different countries and regions. Thank you.
Thank you, Mr. Cole. 除了亚洲放射师持续专业课程，今天同时为粤港澳大湾区放射师学术论坛，让我们欢迎澳门放射师学会理事长于展全先生致辞。现在有请于先生。
大家好，我是于展全。今天是粤港澳大湾区放射师联盟成立了已经3周年了。湾区的同业得到更多的相互学习交流的机会，在此我代表澳门放射师学会特别鸣谢靳俊卫主委、康庄主委、王伯良会长、温兆斌理事长等等，不仅对我们澳门的支持，更是对整个湾区放射师专业的发展的大力支持。希望未来的日子我们的交流会越来越多，合作越来越紧密。谢谢大家。
谢谢于先生。Thank you, Mr. Fernando Kuok and Mr. Dennis Yu Jinqun. A word to all of our panelists. Please stay on your web page, as we are now going to take a group photo now. Ready? 1, 2, 3, smile. Okay, thank you all of you. Over the last 2 years, due to the pandemic situation, as many people as usual haven't visited Macau. So that's why we have made a video clip which is about the scenery of Macau. Please enjoy it.
Close till I get up. Time is barely on our side. I don't wanna waste what's left. The storms we chase are leading us, and love is all we'll ever trust. Yeah, no, I don't wanna waste what's left. And on we'll go, through the wastelands, through the highways, till my shadow turns to sun rays. And shadow turns to sun rays, and on we'll go, through the wastelands, through the highways, and on we'll go. Turn us to thousands, and we'll grow in number, fueled by them to see the horizon. Turn us to thousands, and on we'll go, through the wastelands, through the highways, till my shadow turns to sun rays, and on we'll go. Through the highways, and on we'll go.
学术论坛现在开始，有请第一部分的论坛主持人郑美玉女士。郑女士是澳门放射师学会的会员。
It's time to start our academic forum. Let's welcome our moderator, Ms. Zhang Mei Yok Maggie. Ms. Zhang is the member of MRTA.
Good morning, colleagues and friends. I'm Maggie Zhang. This is the 22nd anniversary of the MRTA. In this session, we have totally 3 speakers. Before our presentation starts, please allow me to introduce a few things about our webinar page. As you can see, there is a Q&A box. If you have questions you want to ask the speaker, you can simply type in your questions in the Q&A box. Also, there is a checkbox for you to check and discuss with each other. Well, let's welcome our first speaker, Ms. Yun Ting Ho. Ms. Ho is the Secretary Director of the MRTA.
Hello everyone, I'm Ho Yun Ting Kobe from Macau Radiological Technologists Association. My topic today is different skills to improve mammography image quality. So let's give a brief introduction about the background of mammography in advance. From WHO data, in 2020, there were about 2.3 million women who were diagnosed with breast cancer, and breast cancer is the most common cancer worldwide. And there has already been 100 years for mammography to be developed. Mammography is now widely used as a screening technique. The main types of breast changes that can be found with a mammography are calcifications, masses, asymmetries, and distortion of the breast. Nowadays, reports show that the breast cancer deaths are down about 30% as a result of early screening by using mammography. The goal of mammographic screening is to detect breast cancer earlier than it would otherwise manifest clinically, and to yield a better patient outcome, lower morbidity, and reduce breast cancer deaths. Then we can go to our main theme, by what skills we can use to improve mammography image quality. Being a radiographer, I have classified those factors that affect image quality of mammography. There are basically 4 groups. The first group are patient-related factors, which include the menstruation, breastfeeding, and implants. The second group is the technical factors, which I mean here are those factors that related to radiographer. And it includes the positioning, compression, and exposure parameters. And the third group is hardware, and it includes the use of CR, DR, and tomosynthesis, which is the 3D mammogram. And the last one is other factors like communication with the patient, routine QA and QC. And here, I would like to discuss the first 3 groups in my presentation, especially the positioning. So let's start with the patient-related factors. The first one is menstruation. Since screening mammography is less sensitive and less specific in women who are younger than 50. One explanation that's why screening mammography is less accurate in younger women is that they have a higher mammographic breast density than do older women. Since younger women has variation in mammographic density over the menstrual cycle, thus the accuracy of mammography among premenopausal women might improve when the breast density is lower. Several studies suggest this situation may occur during the follicular phase, which is the first half of the cycle. However, recent studies show that the variation in mammographic density over the menstrual cycle were very small and non-significant for women. On the other hand, scheduling precisely during week 1 of the menstrual cycle may be quite difficult due to the availability of the appointments, so that it is just a reasonable suggestion. Another benefit to receive mammogram in the first week of the menstrual cycle is that it may reduce the patient's discomfort. The second patient-related factor is breastfeeding. Since the lactating patients have physiologic changes and hormonal changes, and this will result in increased breast volume and also increased water content. And the sensitivities of mammography may be reduced due to the increased parenchymal density. To solve this problem, the patient can try to empty her breast before undergoing the mammography to decrease the parenchymal density, or she can undergo a 3D mammography rather than a 2D mammogram. The last patient-related factor is implant. For patients who has the breast implant, the radiographer can try to push away the implant from the image receptor and reduce the corresponding influence. The method is to lift the patient's breast, and then we can feel for the anterior part of the implant. Place our thumb and forefinger between the breast tissue and the implant. Then we can try to push the implant back to the patient's chest wall, lower the compression pedal, and also pull the patient's breast tissue forward and outward. Most of the case that the patient has implant was very suggested to use the manual exposure technique. Each vendor has suggested their own exposure parameter according to the final breast thickness. Automatic exposure control is only possible when the breast tissue is over the AEC detector. Here we go to discuss the technical factors. The radiographer's general responsibility is centered on patient care and image quality. More specifically, this includes patient positioning, compression, image protection, image processing, and infection control. Positioning is so important because only those portions of the breast which are included on the image can be evaluated for signs of cancer. We do not want to miss any breast tissue as well as any information. So the goals of the mammography positioning is to bring the breast back to its true anatomical position and to obtain a good image quality. Positioning in mammography is not the same as in general radiology, since each patient has different breast sizes and tenderness of the breast are also very different, as shown in this picture. The standard of routine view for mammography is the cranial caudal view, CC view, and the medial lateral oblique view, the MLO view. The CC view is the best visualization of the subareolar, central, medial, posterior medial aspect of the breast, while the MLO view is the complete visualization of the breast parenchyma, and it can be used to visualize the axillary lobes. Before doing the positioning, here I introduce some anatomical landmarks for both positioning and image analysis. They are the perimeter and the posterior nipple line, the PNL. The perimeter includes the lateral, inferior, medial, superior, and extension of the superior border. And the PNL refers to a line drawn both posteriorly and perpendicularly from the nipple towards the pectoral muscle on the mammograms. Although the pectoral muscle is really not part of the breast, it serves as an important anatomical landmark for positioning and image evaluation. So what is a good theme? Let's introduce the image assessment criteria for both CC and MLO view. For the CC view, all the breast tissue should be imaged, of course, and then it should also include both the medial and lateral aspect of the breast, include as much of the breast parenchyma as possible, and there should be a layer of the retroglandular fat between the posterior border of the parenchyma and the edge of the image. The nipple should be in profile, and it should also in the midline of the image breast. Preferably, a portion of the pectoral muscle should be visualized, and the PNL should be within 1 cm of the PNL on the MLO view. Then the criteria for the MLO view, all the breast tissue should be imaged, the pectoral muscle should be fully visualized, and it should be extended to the level of the PNL, and there should be a wide margin of the pectoral muscle at the axilla, and the pectoral muscle should have a convex anterior margin. The nipple should be in profile, and the inframammary fold, the IMF, should be well demonstrated. The IMF is the deflection where the breast tissue meets the chest wall of the below the breast. And then the PNL should be within 1 cm of the PNL on the CC view. And of course, other general criteria is no patient motion. All the breast tissue within the perimeter should be included. The tissue should be well separated. So after the introduction of the criteria, let's see the mammography positioning for a good CC view. First of all, the radiographer should stand on the opposite side to the breast being imaged. Then second, the patient can step back slightly away from the IR, bending forward her waist to allow the breast to fall forward. And this position can bring the breast closer to the IR and allow more medial and posterior tissue to be captured on the image. For the first step, we can place the IR inferior to the breast, and we can instruct the patient to relax her shoulder. Place the patient's hand on the abdomen, below the waist on the examined side, and this position can bring the more medial tissue closer to the IR and include more tissue from the upper outer quadrant and reduce the skin folds. For number 5, we can raise the IR until it touches the inferior margin of the breast. Remember that the IR should not be too high or too low. If the IR is too high, it may stop the patient from leaning forward, and this may eliminate the posterior and inferior breast tissue. In contrast, if the IR is too low, the breast will droop, superior and posterior tissue will be lost in the image. On the other hand, we should keep the patient ipsilateral hand closer at her side in order to get a greater amount of the tissue. Then we can tell the patient to relax, otherwise the pectoral muscle will be tightened, and it will pull up her breast and also prohibit a good compression. For number 8, we can try to capture more medial and lateral tissue and securing the breast. Be careful not to rotate the patient's breast. Then we can compress the breast gradually, slide our hand out toward to the nipple, and place the other hand gently on the patient's back to prohibit the patient's natural movement away from the compression. In some women, an axillary fat pad may overlap the lateral tissue after the compression. To counteract this effect, we can supinate the patient's ipsilateral hand, which will fatten her shoulder area, or we can adjust her shoulder back. So, before introducing the positioning technique of the MLO view, let's review the angulation of the MLO in advance. For the MLO, the plane of the bucket should be parallel to the pectoral muscle in order to image the maximum amount of the tissue, and this angle is usually 30 degrees to 60 degrees from the horizontal. It depends on each patient's breast morphology. Steeper angle about 50 to 60 degrees is for patients with larger foreheads and smaller breasts. Less angle about 30 degrees to 40 degrees is for patients with shorter foreheads and larger breasts. Using an angle that is not parallel to the pectoral muscle will result in less tissue being imaged, as the white image showing here. Some breast tissue was not imaged. You can see there is more tissue. Also, we can keep the angulation of each patient consistent so that we can reproduce the image in the next examination. For the MLO positioning, we can turn the patient feet and body towards the unit at approximately 45 degrees to the edge of the IR. The patient should stand with her hips slightly anterior to the lower part of the IR. If her hips are behind the IR, it will be harder to pull her lateral breast tissue into view. The patient upper arm is horizontal and both shoulders should be at the same level. To determine the height of IR, we can raise the patient arm to the shoulder level, and this will form a right angle with the body. You can see that is the correct angle. If the shoulders are not at the same level and the IR is too low, it is incorrect. As in figure 3, if there is too much of the shoulder and upper axilla under the compression pedal, it will prohibit proper compression of the lower part of the breast. If the IR is too high, like picture 4, the arm will be elevated. It will scratch the pectoral muscle and causing difficulty in pulling the breast tissue into view. And number 5, after we fix the height of the IR, the corner of the IR should be positioned in the posterior aspect of the axilla as shown in picture number 5. Then we can bend the patient elbow and gently rest the patient hand on the lower part of the supporting bar. Here we should tell the patient don't grip the handrail. Otherwise, tension will be generated in the pectoral muscle and it will inhibit the position and compression process. Remember that the patient arm should not entirely rest along the top of the image receptor. Instead, we can bend the patient elbow, rotating her triceps muscle posteriorly and superiorly, like here. And this will help to bring the lateral portion of the breast closer to the positioning surface. Then we can rest only the upper arm of the patient on the IR. In picture 10, the elbow should be rest posterior of the IR. This method can help to minimize the thickness of the upper breast and axilla, and it will also eliminate skin folds in the superior aspect of the MLO view. Then for the last step, we can rotate the patient hip and shoulder inward a little and hold her breast outward and forward. We should flatten the tissue at all times while applying the compression and reduce the structural overlay and to ensure the visualization of the posterior breast tissue and also ensure the visualization of the IMF. So here are some images. Let's check out what problem they have. For the first image, there were some skin fold here. And then for this one, the nipple was not in profile and it was also not at the midline of the breast being imaged. Then for the third one, the IMF is not well demonstrated. For the last one, actually it was a good image without any skin fold. The IMF is well demonstrated, nipples in profile, and the pectoral muscle has a wide margin, and it also extends to the level of the PNL. Only one thing that can be improved is the asymmetry in the width of both pectoral muscle. As we can see here, the pectoral muscle in the right side is a little bit smaller than the pectoral muscle in the left-hand side. Besides the positioning, other technical factor that we can control is compression. Nowadays, this is a basic idea that if we use the compression of the technique, we can reduce the scatter and KVP, which will lead to a higher contrast of the images. And it can lower the MAS, which will reduce the patient radiation dose. This is reports that the scatter fraction can be reduced by almost 50% after we use the compression technique. Compression is also very necessary to separate overlapping breast tissue, and it will minimize artifacts from patient motion or breathing, which in turn produce clearer image of the breast. The typical compression force used in mammography is between 100 to 200 newtons usually. After the compression, we should carefully choose the exposure parameters. Depends on the patient breast thickness and the tenderness. Thank you to the technology, we can use the AEC now. However, in some case when the AEC is not possible, each vendor also has their own suggested exposure parameters for us to input. The radiographer can take this as a reference. So that's finished the discussion of the technical factors. Let's talk about the hardware. So in the past 100 years, pioneers and we have made a lot of the improvement in mammography, from screen film to conventional radiology, and to digital mammography to 3D mammography. There has been a huge improvement in image quality. So let's see the comparison between the DR and CR. The DR, I mean here is the 2D mammography. The DR has increased throughput, sensitivity, and latitude, and etc. This is also easy to see by our eyes that DR has a better image quality than CR in this picture. Although the digital mammography can improve assessment of dense breast tissue, however, overlap of the glandular tissue remains an issue with 2D imaging. So that the 3D mammography has been proposed. It is highly used nowadays, and some medical institutes have even used this technique to replace the 2D mammography for making diagnosis. This technique emphasizes on its better spatial resolution, since it will take images of the breast in different angles, so that for lesion which is overlapped with other tissue, it is more easy to see more clearly by a moving X-ray tube. Besides, the images that can also be combined together to yield a 2D image without increase the patient radiation dose. So that the comparison between the 3D mammography to 2D mammography is that the 3D one has increased specificity, increased spatial resolution, and it will decrease false positive and false negative findings, etc. So let's summarize today's presentation. So for the first one, if possible, we can try to schedule the mammography at the follicular phase, which is the first half of the menstrual cycle. Although it is shown that the breast density changes during the menstrual phase are very small, but some patients still feel that it was less discomfort in this period. The second, for lactating mother, she can try to empty her breast before doing the mammography, or she can choose to undergo a 3D mammography instead to the traditional 2D mammogram. For patients who has implant, the radiographers can try to push away the implant when they are doing the positioning, and we can choose the suitable exposure parameters for this patient. Then for the technical factors, what we should do is to keep in mind the standard of a good image. Then we can try to use different skills to achieve this standard. Use the optimal compression force and the suitable exposure parameters. Then for the hardware, there is no doubt that we should use the digital mammography. In some cases, the 3D mammography is used as a complementary technique, although nowadays many facilities has used it as a routine mammography. Lastly, a good communication with the patient. Let her cooperate with us will help us to get a good image. Also, constant QA and QC procedure is also very important for us to maintain the good image quality in our medical service. So this is my reference, and that's the end of my presentation. Thank you.
Thank you, Ms. Ho, for your talk. Let's welcome our next speaker, Ms. Kayan Lo. Ms. Low is a member of the MRTA.
Good morning, everyone. I'm Nathaniel from Macau Radiological Technologists Association. Today, my topic is CT, a new alternative to breast imaging. Currently, there are three major breast imaging modalities running in our daily clinical practice. They are mammography, ultrasound, and MRI. Mammography is a frontline image and the standardized imaging in breast screening program. Ultrasound acts as a supplementary imaging for suspected lesion finding in mammogram, especially those in dense mammo. Also as a following up tool for lung calcification associated lesion like cyst. MRI is an advanced imaging for those who need surgical plans. Consider from different aspects listed in this table. Mammography is an easy access modality with good performance in early detection ability and radiation dose. The best cost performance value brings mammogram as the frontline modality and golden standard tool in breast cancer screening program. However, nothing is perfect in the world. There are still some unavoidable disadvantages in mammography, such as painful compression to patient, degraded image quality in dense and implant breast, and also the tissue overlapping into the imaging. In the past, CT is not considered as a choice for breast imaging mainly because of its high radiation dose and unrecognized ability in early detection. The CT components has been changed for several generations. Probably the concept can be changed in recent days. The concept of putting CT for breast image started in 1970s. However, comparing the mammo technique at that time, CT is not good at the point of view from resolution and dose. Later, thanks to the development of cone beam CT and TFT detector, they opened a new page to the CT breast imaging. We can have an isotope pixel in breast CT image and also a compatible dose like 4.5 microgram to the mammogram. Fusion image like SPECT CT, PET CT is developed at the same time. Researchers try to use small focal spot to improve resolution of breast CT with CMOS detector. But the result is not optimal because the tube current is low and also the scan time around 100 seconds is too long for the real situation. So at this moment, most of the breast imaging is running in laboratory and or researching center until this moment. The first commercial breast CT scan by Pengurus Company is launched in 2012. CE mark is received and is authorized by FDA in 2015. But we look carefully in that. In the state of FDA, it says this breast CT is for the breast cancer diagnostic for suspicious sign or have abnormal findings in other image modality, and it is not intended for breast cancer screening. In 2018, a new generation CT named as New View is launched. This new generation CT is embedded with cone beam CT and photo counting detector. Okay, at the first let's have some concepts on the difference between the energy in integrated detector EID and also the photo counting detector PID. Okay, on the left hand side is the EID detector. The EID, the incident X-ray is first absorbed in the layer and change to visible light, and the photodiode measure the light and generate electronic sign. This is what we call two-step indirect conversion. And on the right hand side is a new PCD, and we can see that the incident X-ray is measured directly by generating a cloud of positive and negative charges. The electronic circuits separate and pull them away quickly and register them as electronic signal. And this is what we call one-step direct conversion. And the one-step conversion and two-step conversion makes difference between this detector. Let's have a look on that. Okay, the two-step conversion of EID requiring reflecting material between every single element for controlling the visible light, and this layer are considered as a dead space for signal. We can make smaller pixel, that means smaller single element, to improve the resolution in CT. But for the same FOV, increasing number of elements cause too much dead space if we are using EID detector. For PCD, there is no need for one-step direct conversion to have isolation material between each element to control lights. Ultra small elements are lined up one by one, stick together without depth space to perform ultra high resolution CT. In traditional EID, the two-step conversion requires longer response time for signal detection. Pulse under loss level is read and mixed together with the real signal because of the happening of crosstalk. Therefore, finally, degraded the image quality. But for the PCD, which is one-step conversion, the image shown is in the lower part of this PPT, and the short responsible time helps the system to clarify the noise and exclude them from the real signal. Therefore, the noise can be eliminated. The longer responsible time of the two-step EID also undergraded the contribution of the low energy photo. Let's see in the upper image. There are actually 4 photons coming into the detector, but only 2 mixed signal is finally without, and they are all higher energy weighted. The contribution of the lower energy is not read, and finally the overall energy profile is high energy dominate. Okay, and on the lower part of this PPT, and we can see the shorter responsive time in PCD somehow help to settle this problem, as we can see the lower and higher energy photo contribute the same weighted as they are detected one by one by the system. The structure and the signal generator mechanism of PCD comes up a better use of every photon coming up into the detector. The dose efficiency is higher then. The SNR, CNR is improved also at the same time. On the other point of view, less radiation dose can be applied to get the same quality image in PCD. The performance of the image quality and dose is what we concern the most for putting CT in breast imaging. As we can see, PCD provides better performance than in the traditional EID detector. So, overall speaking, how is the performance of breast CT with PCD compared to mammogram? Okay, let's have some concepts for the structure and procedure for the breast CT first. Okay, this is the picture for the breast CT scanner, and there is a cone on the top of the scanner. The patient is prone and breast is put in the breast cover. The tube and the detector is on the table and rotate around the single breast and get the image. So we are using 60 kV 5 to 125 mA cone beam CT, and the scan time is 7 to 12 seconds for single breast exam, and the pixel size is 0.1 and on EXO, while it's 0.15 mm in voxel. So a filter back projection reconstruction method is used. Okay, let's have a look on the performance of resolution in breast CT comparing to mammogram. And since there is no compression to the breast, so the breast thickness in the CT is higher, and will cause the possibility of motion artifact increase, and we have a longer scan time compared to mammogram. It also causes probably the motion artifact possibility is higher also, and we have a higher kV used in the breast CT to pass through a thicker breast. So the detector thickness is increased at this point. So overall speaking, the resolution in breast CT is lower than in the mammogram. Okay, the next aspect is about the radiation dose. There is a guideline of FDA actually. This said that is a 3 mg dose per view in mammogram, and it is under the condition of average 4.2 centimeter thickness of the breast tissue, and the composition is 50-50 adipose and glandular tissues. And there is a phantom study about the dose of breast CT in 2010, and it found that the breast CT got a 8.2 average for single breast of the radiation dose, and mammogram is 6.1 for 2 view for single breast. So it is 25% higher in breast CT. But for the clinical consideration, that means that because mammogram is a more operator dependent and also patient dependent on the positioning. So sometimes we have to repeat the image because of the failure or unqualified positioning. So the team also put this kind of clinical consideration into their research in 2012 and found out that the dose actually is more stable in breast CT. Okay, then we have a summary and conclusion for today's topic. And until this moment, it still lack of large population research for the performance of breast CT to be the first line tool in breast screening program. However, for those who are fear of painful of mammogram, or for those who have contraindication like pacemaker, claustrophobia, contrast medium allergy in MRI, breast CT is an alternative image modality for them clinically. And for further clinical practice, as listed below, like subspectral microscopications in dense breast, contrast medium, or we want contrast medium providing some information about the blood supply information for the lesion in your breast, or we want a less scanning time compared to MRI speaking to plan for a surgery, and we want a routine or period monitoring after the chemotherapy, and we don't want to spend as long as time scanning time in MRI. We can have a CT breast image actually. So these are my references, and thank you for your attention.
Thank you, Ms. Lo, for your lecture. Our first speaker is Ms. Cecilia Loguera Lee. Ms. Lee is the supervisor of the MRTA.
Hello, my name is Cecilia. My topic is mammography in MRI. I will mainly focus in how to perform a good dynamic contrast enhanced MRI according to the latest guideline of ASIA. First, this is my outline. I will briefly introduce what is dynamic contrast enhanced breast MRI, and then I will talk about the type of time signal intensity curves, how to differentiate between benign and malignant lesions based on their kinetic curve. Then I will talk about all the challenges we might face in performing dynamic contrast enhanced MRI. Mammography is limited by its low sensitivity, and dense breast tissue can mask cancer detection. Breast MRI is recommended by the American Cancer Society as an adjunct to mammography for screening women who are at high risk of developing breast cancer. Dynamic contrast enhanced MRI using a gadolinium-based contrast agent provide a high-intensity distinction between normal and diseased breast tissue, making it sensitive to breast tissue composition and microvascularity. Breast dynamic contrast enhanced MRI includes multiple post-contrast sequences acquired at different time points after the injection of MRI contrast agent. The time signal intensity curve, TIC, from dynamic contrast enhanced MRI reflects the hemodynamic features of a specific lesion. It is obtained from multiple post-contrast sequences, and it reflects dynamic signal intensity changes induced by uptake of contrast agent over time. And it can be also described as contrast enhancement kinetics. A qualified TIC usually takes 12 minutes to complete the scans. Temporal resolution is the main determinant in affecting the time signal intensity curve. Higher temporal resolution means a smoother TIC, which leads to more detailed and accurate results. The kinetic curve can be classified into 3 categories. Early enhancement, which is around 2 minutes after contrast agent injection. The enhanced curve can be divided into slow, medium, or rapid. If the slope is steep in the initial, which is highly suggestive of malignancy. The signal intensity 2 minutes after contrast injection is defined as delayed phase, which is divided into persistent type 1, plateau type 2, and washout type 3. The initial rise usually reflects the scope of tumor angiogenesis, whereas the delay phase reflects the formation of tumor cells. Persistent type 1 is a pattern of progressive enhancement with continuous increase in signal intensity. Persistent curve usually considered benign lesion with only a small portion, around 9% of malignant lesion having this pattern. Plateau, which is type 2. The signal intensity reaches a peak 2 minutes after contrast medium injection, followed by a flattening during the delay phase. Plateau curve usually suspicious for malignancy, but not all the plateau curve means malignancy. Washout, which is type 3, we can see that there is an initial increase after contrast medium injection and a significant decrease in signal intensity 2 minutes after. Washout curve is considered strongly suggestive of malignancy. Here are the challenges we will face when performing dynamic conscious enhancement of breast MRI. First, the conscious agent shortens the T1 of the lesion relative to the surrounding normal tissues, and it may detect as bright region on T1 weighted images. So there will be a challenge in maintaining an SNR. Secondly, the breast has significant fatty tissues. Therefore, fat suppression is very important in breast MRI. Then a high spectral resolution should be used for small lesion detection and shape assessment. So how to achieve a high spectral resolution is critical. Time signal intensity curves are critical to differentiation of benign and malignant masses, but it can only obtained with good temporal resolution. Therefore, high temporal resolution is essential. But unfortunately, all of the parameters above are compete with one another, so an artifact-free dynamic conscious enhancement breast images is very difficult to obtain. And also, an MR pulse sequence that can meet all of these technical requirements above would be a significant challenge for us. So now I will introduce some recommendations from ACR in performing dynamic conscious enhancement of breast MRI. According to American College of Radiology, all sequences must demonstrate significant SNR and do not appear too grainy. The details of the pulse sequences, along with other selected parameters such as imaging matrix and number of signal acquisition required, will determine the image acquisition time and SNR. In general, short acquisition times are desirable to limit patient motions and discomfort and provide flexibility. However, if the overall image quality, SNR, and diagnostic value is compromised, short acquisition time should not be employed. ACR also suggests that fat suppression should be used in dynamic conscious enhanced breast MRI. There are two main methods we can use in fat suppression, such as inversion recovery. The sequence starts with a 180 RF inversion wave which flips the longitudinal methanization in the opposite direction. Due to the longitudinal relaxation, longitudinal methanization will be increased to return to its initial value, passing through null value. To measure the signal, a RF wave is applied to obtain transverse methanization. The delay between 180 RF inversion wave and the 90 RF excitation wave is referred to as its inversion time. For inversion time for fat is around 160 to 170 milliseconds. The second method we commonly use are frequency selective fat suppression. The diagram of the right shows how signals from water and fat protons resonate in two peaks, separated by about 220 Hz at 1.5 T MRI and 440 Hz in 3 T MRI. Because of this natural separation, it is possible to saturate the fat peak only by applying a narrow bandwidth RF probe tuned to the center of lipid resonance. When a standard imaging sequence is performed, the saturated fat protons will not generate an MRI signal, resulting in a fat suppressed image. So, high spectral resolution is used for small lesion detection and shape assessment. How can we increase spectral resolution? There are 5 determinants of voxel determination in an MRI examinations. Alteration in any of these 5 parameters will change the voxel volume. Alterations in the number of phase encoding steps affect scan times, while alterations in the number of frequency encoding steps may affect the maximum number of slides as well as the minimum possible TE for the imaging sequences. Voxels that are too large for the anatomic structures being examined cause the viewer to observe what is perceived as blurriness in the image, while decrease the size of the voxels has the potential to increase the sharpness of the image, but decrease in SNR. The breast MRI accreditation program requirements for spatial resolution for the T1 weighted multi-phase series are as follows. The slide thickness must be less than 3 mm. The in-plane pixel resolution must be less than 1 mm for both phase and frequency directions. Slide thickness sets the limits on the smallest lesions that can be imaged without slight partial volume effects decreasing lesion contrast. Although slide thickness may not impair visualization of high contrast lesions that enhance dramatically, it can play an important role in detection of low contrast lesions. To image a low contrast lesions of a given diameter without partial volume effects, which would decrease its contrast relative to surrounding tissues, a slide thickness of half the lesion's diameter or less should be used. Thin slices are particularly important for minimizing partial volume effects on diffuse, long-mask light enhancing lesions. According to ACR, the in-plane pixel resolution must be less than 1 mm for both phase and frequency directions. It can be achieved by selecting an acquisition matrix that exceeds the FOV in both the phase encoding and frequency encoding direction, which will give an excellent spatial resolution. Sub-millimeter in-plane pixels are important for good lesion margin visualization, which helps distinguish benign from malignant enhancing lesion based on their morphology. The temporal resolution relates to the duration of time for acquisition of a single frame of a dynamic process. As I mentioned before, a higher temporal resolution means a smoother time intensity curve. So, how to improve temporal resolution? There are few factors affecting temporal resolution, which is number of contrast enhanced sequences, TR, bandwidth, and the scan time of each sequences. According to various studies, the peak contrast enhancement in malignant lesions typically occur between 60 to 120 seconds after injection. As you can see here, the left diagram, if we increase the sampling rate, which means we obtain more sequences in a short period of time, we can see that the time intensity curve will be more detailed and accurate. And the right image is the kinetic curve of different temporal resolution datasets for the lesions. The kinetic curve shape was washed out for the 50, 30, and 45 second acquisition data, but was plateaued for the 60-second temporal acquisition data, which means that shorter scan time per sequences provide better time intensity curve. Temporal resolution is very important in providing a correct enhancement curve classification, which may lead to more accurate in categorizing benign lesions and malignant lesions. But increased temporal resolution for dynamic conscious enhanced MRI of breast may result in higher noise level and lower SNR. In MRI, there are constant battle between spatial resolution and temporal resolutions. Adequate temporal resolution is necessary to evaluate conscious enhancement kinetics, maximize the lesions to parenchyma, conscious differentiation to improve lesion detection, and also analysis of morphologic details. However, high temporal resolutions may result in higher noise level and lower SNR. Increased spatial resolution significantly improve diagnostic confidence and accuracy at dynamic conscious enhanced MRI. Even if this improvement occurs at the expense of temporal resolution. Therefore, in dynamic conscious enhancement breast MRI, balance all the parameters is key. It is important that we know how to balance these parameters in order to provide significant information for doctors in diagnosis. So here is my references. Thank you very much.
Thank you, Ms. Lee, for your lecture. Thank you for the informative talks of our three speakers. This session ends here.
感谢郑美玉女士。接下来将播放一段视频，请各位悉心欣赏。下一节论坛将于15分钟之后开始。谢谢。
Thank you, Ms. Zhang. Please enjoy a video clip we have prepared for you. Next section will start in 15 minutes. Thank you.
The road to innovation is long. It takes passion and expertise, craftsmanship and collaboration. But most importantly, it takes drive. The drive to improve clinical and operational outcomes with smart imaging technologies that leverage the latest AI innovations and push the boundaries of high-resolution image quality. At Canon Medical, we are committed to innovating, with your success in mind. No matter how far the journey takes us, we are here to help you and your patients get the best treatment, clinical and business outcomes possible. Outcomes-driven innovation. Made possible by Canon Medical. Made for life.
The technical efficacy of a gadolinium-based contrast agent depends on its relaxivity. That is, by how much T1 relaxation time is shortened. For efficient relaxation, water molecules need to bind directly to the inner coordination sphere of the gadolinium ion. By getting close to the gadolinium, each water molecule relaxes and then exchanges rapidly with the next water molecule. The molecular structure of the GBCA determines how effectively this happens. The macrocyclic GBCA gadovist has a special molecular structure with 3 hydroxyl groups. Those 3 hydroxyl groups retain water molecules through hydrogen bonding to build a large hydration sphere around the gadolinium, which is also called the second sphere. Now, not only do the water molecules in the inner sphere relax, the water molecules in the second sphere are close enough to the gadolinium ion to relax as well. The ability of gadovist to support both inner sphere and second sphere interaction with water molecules results in high relaxivity, leading to an enhanced signal intensity on the MR image. With its special molecular structure, gadovist shortens T1 relaxation time more efficiently than other macrocyclic contrast agents, which could enhance image quality and improve diagnostic confidence.
Are you looking for a system that makes it fast and easy to ramp up productivity and deliver exceptional quality images? Discover Philips MR 5300. It takes our revolutionary helium-free MR operations to the next level. With AI-driven breakthroughs designed to automate the most complex tasks so you can focus on your patients. Smart workflow combined with our lightest and most versatile breeze coils reduces the number of steps needed to complete an MR exam. You can set up patients in under a minute and accelerate change over time by up to 30%, while the MR 5300's innovative Comfort Plus mattress simplifies cable handling. Compressed Sense speeds MR scans by up to 50% with virtually equal image quality. With MR 5300, it is possible to scan routine exams like the brain and knee in just 5 minutes, freeing up time slots for additional patients. You can count on high-quality clinical images thanks to the new versatile breeze coils and robust scanning methods, even when imaging the most challenging anatomies and the smallest joints. And to lower the total cost of ownership, our service solutions assure performance for life. Make the smart choice with Philips MR 5300.
perception, understanding, reasoning, creativity, wisdom, learning, intelligence. The ability to think abstractly and rationally and use that thought for purposeful action, the strongest tool of humankind. And a concept that we have pushed even further, making technology our strongest partner and giving us the confidence we need to make the right decisions intelligently. My exam companion is intelligence that works with you. It uses the new possibilities of digitalization to turn data into built-in expertise. To unlock the full potential of Somatome Excite. My exam companion helps users on their way to the consistent results that radiologists need. My exam companion, intelligence that works with you.
迎各位回到学术论坛的第二部分，粤港澳大湾区放射式学术论坛。有请本节的主持人欧之兴先生。欧先生是澳门放射师学会的学术部长。
Welcome back to the academic forum, which is the Radiological Technologists Forum of Guangdong, Hong Kong, Macau Greater Bay Area. Let's welcome our moderator, Mr. Ao-Ji Yan Edwin, who is the academic director of MRTA.
Hello, welcome back to the second part of our academic forum. Let's welcome our fourth speaker, Mr. Hui Yuan. Mr. Yuan comes from the Department of Nuclear Medicine, Guangdong Provincial People's Hospital, Guangdong Academy of Medical Science, China. Today, his topic is nuclear medicine for pre- and post-surgical evaluation of breast cancer, role of hybrid imaging. Let's welcome Mr. Yuan.
Hello everyone, welcome to this lecture. I am Yuan Hui from Department of Nuclear Medicine, Guangdong Provincial People's Hospital, Guangdong Academy of Medical Sciences. I'm glad to come here to present and to share our experience of interpreting hybrid imaging for breast cancers. Let's start. Cancer is the leading cause of mortalities worldwide, of which breast cancer is common and is increasing fastly in its incidence. And in 2080, breast cancer was listed as the second most common cancers. However, in 2020, it has become the most common cancers, exceeding lung cancers. One of the astonishing facts is that you have to know breast cancer literally affects only female, while the lung cancer affects both genders. So you can imagine what's the incidence of breast cancer among females. Imaging-based evaluation for breast cancer is basically mandatory, and the NCCN Guidelines version 5 2020 stated that for different stages and different situations, different modalities, imaging-based modalities should be selected. As for this one, the very early stages, only breast MRI is indicated. However, for the very early stage breast cancer after the treatment, especially after surgery, only mammogram is indicated for the follow-up. For the staging, of course, the primary lesion is usually evaluated by ultrasound or breast MRI. However, for distant metastasis, here we can see that the bone scans, either by bone scintigraphy or the sodium fluoride PET-CT scans, and abdominal and pelvic diagnostic CT with contrast enhancement or MRI with contrast enhancement is usually necessary. And chest CT is important for the evaluation of lung metastasis. And here, PET-CT is optional. For patients with very advanced stages, that means the patient has distant metastasis or the patient with recurrent breast cancers. The imaging workup usually involves the CT with contrast, MRI with contrast, and again, PET-CT is optional. Well, before the initiation of preoperative systemic therapy, CT with contrast enhancement or MRI with contrast enhancement is necessary, and FDG PET-CT scan remains optional. Well, pretty disappointing, right? After reading the NCCN guidelines, the PET-CT, which is the most widely used nuclear medicine imaging modality, remains optional in most situations. However, the conventional radiological scanning modalities, especially CT and MRI with contrast enhancement, is still very necessary and almost mandatory. However, with the advent of hybrid imaging, especially PET MRI, can we offer more comprehensive evaluation and played a more important role in guiding the management of breast cancer? We can see. Here is a real case of a patient with breast cancers who takes contrast-enhanced CT and PET-CT within the same scanner. As we can see that there is a huge mass located within the left breast, and in the PET part it uptakes a lot of FDG, and the central part is hypometabolic, indicating the central part necrosis. The contrast-enhanced CT demonstrated rim enhancement, and of course, we have a closer look. It shows that lesion invades the chest wall as well as the skin. Hence, PET-CT with contrast-enhanced CT might offer better evaluation of the breast cancers, and the combine of these two modalities might be recommended. Here is another real case. This is a female, 57 years old. He has a history of breast cancer, which is histologically proven. The cancer was located in the left side, and he had mastectomy of the left side. And after the completion of the surgery, he had 6 cycles of chemotherapy, and he came back for post-treatment evaluation. The patient had her prior treatment elsewhere in another institute, so unfortunately we don't have her prior imaging for comparison. She came to our hospital for staging and had whole body PET-CT scans in our department. So let's look at the imaging. We see basically 2 hypermetabolic lesions. One in the left-sided chest wall, which is just beneath the skin with the left side breast removed, in keeping with her prior surgery. And another one in the mesenteric area. And the unenhanced CT shows really not many of the details. Probably metastasis, local recurrence with metastasis, right? And just wait a moment. Let's see her contrast-enhanced CT. Well, let's have a clear look at the contrast-enhanced CT of both lesions. First, let's look at the left side, the chest wall lesions. The contrast-enhanced CT imaging demonstrated a larger enhancement with spiculated margins and irregular shapes. As it is still hypermetabolic and located adjacent to the surgical region, we still cannot exclude local recurrence, right? Remains unclear. Okay, let's look at just to the right side. The mesenteric area, we see a larger lesion with vivid contrast enhancement. The margin is clear, with no evidence of lesion invasion to its adjacent structures. And it seems that it's very close to a small intestine, right? So, at least when we look at this, we thought it might not be a metastasis, and we actually consider it as a GIST or a neuroendocrine tumor. Guided by the imaging findings, the clinicians thought the patient had a local recurrence, while the mesenteric lesion is something else, likely a GIST. So the patient received 2 surgeries, one at the chest wall to remove the local recurrence, and the other one at the intestines to remove the suspicious GIST. Well, the histological studies revealed the chest wall lesion to be purely inflammatory, with no malignant cell identified. So the patient is not suffering from local recurrence. The intestinal lesion turned out to be a GIST, low risk, and the patient received further treatment to that, and the patient is not suffering from distant metastasis. Very lucky, right? let's see another case. This is a 64-year-old female with discomfort of the abdominal area for 6 months. She had prior endoscopic and laparoscopic biopsy and find undifferentiated adenocarcinoma and without no origin. So a PET scan was indicated for a comprehensive evaluation. Have a brief look of the MIP. We don't see a lot of hypermetabolic foci. And by a deeper look of the unenhanced PET-CT scans, we can see some enlarged axillary lobes with mild FDG uptake, and the mesenteric area is somehow opacified, but is eumetabolic, and the colon and the rectum wall are very hypermetabolic. So what's the diagnosis? Well, let's continue to view this imaging and have a look of the skeletal system. We see a lot of hyperdense small lesions across the whole body, and all of the lesions are eumetabolic. So what is the diagnosis now? Well, contrast-enhanced CT were added. You can see that the wall of rectum and the colon remains intact, but the hypermetabolic, likely due to the physiologic uptake. However, the left axillary lobes were enlarged with very vivid enhancement and might be metastatic, right? And look at the bones. Bones. Look at the spines, and we magnify. You see a lot of these lesions. Eumetabolic. Are they metastasis? The diagnosis remains unclear. Then what should we do? How about adding another modality? So the patient received the MRI scan, and luckily we had an MRI scan here. And we see quite a lot of these lesions throughout the whole spine. And what is your diagnosis now? Metastasis? Well, as the imaging diagnosis remains unclear, the patient received biopsies at the axillary nodes and, of course, CT-guided bone biopsy. The lymph node biopsy revealed breast cancer, invasive lobular carcinoma, while the bone biopsies showed metastatic cancer, likely breast origin. So finally, we conclude that the patient is metastatic breast cancer, but the original malignancy remains unidentified. Of course, PET and MRI can be combined in another manner. That's the PET MRI scanner, simultaneous scan. And for breast cancer evaluation, PET MRI can offer a comprehensive evaluation, which will depict the exact extent of the local disease and local regional lymph nodes. And also it's very good for systemic staging, and the findings might change clinical management. And one of the most important thing is that comparing with PET-CT and especially PET with contrast-enhanced CT is significantly less in radiation dose. So it might be indicated for both PET-CT and organ-specific MRI or PET-MRI whole body scans, as PET-MRI is superior to PET-CT, especially for extra-axillary node and distant diseases, especially in case of hepatic lesions and bone lesions. But is PET-MRI always helpful in the clinical management? Luckily, we had a PET-MRI here, and here is another case of our experiences. This is a 62-year-old female who was newly diagnosed to have CA breast. He had a proven nodal metastasis to the left axilla and came here for staging to plan her further treatment. If we look briefly to the MIP imaging, we saw basically two lesions in the left side. One is the breast mass and one is the small axillary lobes. And a further investigation into the transaxial non-enhanced PET-CT scans, we saw clearly a mass within the breast and a node in the left axilla region. These are typical lesions. But if you look at the right side, the axilla area, we do notice some slightly enlarged lymph nodes with mild uptake of FDG. What is the diagnosis now? Of course, in the contrast-enhanced CT, the left-sided lesion is very typical, so we will not discuss that further. However, interestingly, we see a hyperdense lesion in the right-sided breast and a slightly enlarged lymph node of the right axilla. And in the CT imaging, we feel that the right-sided breast lesion is likely to be benign, and the right axilla node is more likely to be reactive, right? The patient received chest PET-MRI scans for the evaluation of the breast lesions. Well, again, the left-sided lesions are very typical, so we will not further discuss these lesions. Trouble comes from the right-sided lesions. The right breast lesion, although looks very benign, still presented a little bit size of diffusion restriction, as well as the right-sided lymph nodes. Well, the diagnosis remains unclear, right? So what else can we add? Of course, contrast-enhanced MRI. And we selected this plane showing the right-sided enlarged axilla node with vivid enhancement, very hypervascular. So when we saw this, we actually gave a diagnosis that this is likely to be a CA breast with bilateral axilla nodal spread. Of course, the patient then had a surgery to remove the breast mass and to have biopsies at the axilla nodes at both sides. Well, the left-sided breast mass is, of course, unsurprisingly, breast cancer. The right axilla node, however, are all inflammatory and reactive in nature. And the right breast larger with hyperdense lesions inside of it is actually a fibroadenoma with extensive calcifications. Hybrid imaging might offer complementary information in most situations, and they do help the diagnosis, right? But as we saw in the prior case, sometimes they do offer contradictory informations as well. In these situations, they cause diagnostic dilemmas. When they offer contradictory informations and the diagnosis is difficult, we need to comprehensively evaluate the patient, including the imaging information and, of course, the clinical characteristics. Furthermore, the accumulation of experiences to interpret hybrid imaging is still needed. And thanks for your listening. That's all our stories here, and you are very welcome to contact me via this email. Thanks very much.
Thank you, Mr. Yun, for your lecture. Now, we move on to the next speaker. Here comes our last speaker, Mr. Gavin Chun-Kit Chen. He is acting senior dosimetrist of the Department of Radiotherapy, Hong Kong Sanatorium and Hospital, Hong Kong SAR, China. Today, his topic is early experience of using CyberKnife for local recurrence partial breast irradiation. Let's welcome Mr. Chen.
Good morning, everyone. Today, the topic that I'm going to share with you is early experience of using CyberKnife for local recurrence partial breast irradiation. In this presentation, our early experience will be reported on the technical feasibility and rationale of using CyberKnife for local recurrent breast cancer. The dose results of lungs, heart, spinal cord, contralateral breast, and conformity index in CyberKnife will report and compare with tomotherapy. The future perspective of CyberKnife for stereotactic partial breast irradiation will also be discussed. Let's have a brief introduction to CyberKnife. The CyberKnife linear accelerator is a robotic stereotactic radiotherapy system which could provide image guardians for continuous tracking of respiratory target motion and automatic correction of beam in real time as patient breathes. It has emerged as an alternative to conventional brachytherapy and external beam radiotherapy for local recurrence partial breast irradiation. The lightweight 6 MV linear accelerator with output of 1000 MU per minute is directly mounted on a robotic arm in CyberKnife system, with 6-axis rotation to deliver the high-energy X-ray for non-coplanar radiation therapy. Moreover, the RoboCouch system provides a flexible 6-degree motion for patient positioning. The robot moves around the patient to deliver radiation. It can position to more than 100 specific locations, or we call them nodes. Each node has 12 possible approach angles, and therefore it can potentially have more than 1,200 unique beam positions. The CyberKnife delivery system uses KV X-ray imaging to check the targets through the treatment. The imaging system consists of 2 ceiling-mounted X-ray sources and 2 corresponding in-4 image detectors. Live digitized X-ray images are compared with DRR from the treatment plan. During treatment, the image system automatically adjusts the robot position to ensure constant beam accuracy throughout treatment. The CyberKnife features 3 collimator housing types: fixed cone, iris with variable aperture, and the Insight 2 multi-leaf collimator. There are 12 circular field sizes for fixed cone and iris. The field sizes are ranging from 5 mm to 60 mm. Planner can choose the best collimator for the given treatment during the planning process. The Insight 2 multi-leaf collimator has 41 leaf pairs with 2.5 mm width. It creates highly conformal beam shapes to adapt the treatment targets and has a larger field size than iris or fixed cone. The maximum field size is 120 mm by 100 mm. It enables the system to treat much larger targets with significantly fewer beams and MU. Collimator housing types are automatically changed by the Exchange robotic collimator changer, as seen in this movie. There are 5 types of tracking modes in CyberKnife. The first one is the 60-couch tracking. It allows direct tracking of the bony anatomy of the scalp when treating intracranial lesions. The second one is the Excite Spine tracking systems. It enables the tracking of skeletal structures in the cervical, thoracic, lumbar, and sacral regions of the spine without the need of the fiducial implantation. The third one is the Excite Lung tracking system. It tracks tumor in the lungs directly without the use of fiducials by using image intensity differences between the lesion and the background. The fourth one is 6D fiducial tracking. It is used for lesions that are located extracranially. Target tracking can be carried out with the use of fiducials. The last one is synchrony respiratory tracking. It was a tracking method that we used for the partial breast radiotherapy in this presentation. It can continuously synchronize treatment beam delivered to the target, which is moving with respiration. It can be used in conjunction with the 6D fiducial tracking. The system creates a correlation model between patient's breathing pattern and the location of the targets at various points in the respiratory cycle. This is an overview of CyberKnife M6 series. Let's see the medical history of both partial breast radiotherapy cases. They are both the local recurrent left breast cancer. Case 1 is a 60-year-old lady. She was diagnosed with early-stage left breast cancer in 2004. Left breast lumpectomy, chemotherapy, and radiotherapy of 50 gray by using tangential opposing technique with 10 gray electron boost to lumpectomy site was done in 2004. Then, after 70 years, left breast local recurrence was found in 2021. She was then performed while local excision of left breast and fiducial for CyberKnife were placed during the surgical procedures. After that, a total 35 grade CyberKnife partial breast treatment was done twice a day in 10 sections. And case 2 is a 32-year-old lady. She was diagnosed with early-stage left breast cancer in 2020. Left breast microdiscectomy, lumpectomy, chemotherapy, and radiotherapy of 40.5 grade for whole breast with 45 grade concomitant boosts were done in 2020 by using volumetric arc therapy. Unfortunately, about 2 years later in 2022, left breast local recurrence was found. Then, left breast lumpectomy was done and fiducial for CyberKnife treatment were placed during surgical procedures. After that, the CyberKnife partial breast treatment for total 40 grade in 20 sections was given. In fact, apart from CyberKnife, there are other radiotherapy modalities that could be an alternative treatment for local recurrent breast cancer. So why we choose CyberKnife? Before answering this question, let's take a quick look for other possible radiotherapy modalities. The first and the most popular one is the external beam radiotherapy by using 3D conformal, MRTA, and REMAT. They are non-invasive radiotherapy and are available at most RT centers which have equipped with a linear accelerator. The disadvantage, however, they need larger margin, ranging from 8 mm to 10 mm to cover the whole risk area surrounding the cavity to compensate for the setup uncertainty and respiratory motion during treatment. This could be a result in greater radiation toxicity to surrounding organs at risk, such as lungs, heart, and chest wall. The second one is multi-catheter brachytherapy. It is the oldest partial breast radiotherapy technique and has an excellent tumor control rate. Unlike external beam radiotherapy that patients need to attend up to 15 sections, it is a high-dose hypofractionated treatment procedures, and patients only need to attend several times for treatment. Besides, the characteristic of its rapid dose fall-off can minimize the radiation toxicity of surrounding organs. However, it is an invasive treatment procedure and carries the risk of infection, and the treatment procedure is quite complex to perform. The last one is intraoperative brachytherapy. It is a one-off treatment procedure. The low-energy X-ray, usually 50 kV, is delivered directly to the tumor bed during a lumpectomy by using intraoperative cone and leaving the healthy tissue alone. The main advantages is that the treatment is administered before the pathological status of surgical margins and lymph nodes are known, which may sometimes necessary to have additional radiotherapy boosts after that. Now, by using CyberKnife, we could bring together all the advantages of external beam radiotherapy and brachytherapy. First of all, it is a non-invasive treatment procedure. The synchrony and 6D fiducial tracking provides real-time image guidance for respiratory targets. Target margin could therefore be reduced and hence less radiation toxicity to neighbor organs. Moreover, the non-coplanar with radiotherapies enable highly conformal target coverage and could mimic the rapid dose fall-off in brachytherapy impact, which could reduce radiation dose for irradiated organs. Finally, hypofractionated treatment is always adopted in CyberKnife because of its accuracy of tracking and rapid dose fall-off. And these are the reasons why we choose CyberKnife for treating the local recurrent breast cancer. Now, let's have a look at the pre-treatment preparation of CyberKnife for both local recurrent breast cases. The first step was fiducial implantation. The fiducial implantation for both of cases were done during lumpectomy. 4 to 5 thread-like gold anchor markers, as seen in this picture, were placed during lumpectomy by oncologists. For optimal tracking, placement of fiducial is regulated by several principles. First of all, at least 3 fiducials are required to implant for 6D tracking with a minimum of 2 cm spacing between fiducials in order to minimize uncertainty in measuring rotation. Secondly, the fiducial should be placed no more than 5 to 6 cm away from lesions. Finally, fiducial placement should be non-coplanar, and there is at least a 15-degree angular separation between any grouping of 3 fiducials. After the fiducial implantation, in order to ensure the wound healing and fiducial settlement, the planning CT was performed 2 weeks after fiducial implantation. Both patients were rest in supine position on wedlock with their arms by side. The computer planning was begun after target was contoured by oncologists. However, in order to make sure the treatment was succeed, we would conduct a synchrony and fiducial tracking drill in CyberKnife before starting treatment. In case the tracking is failed, we would inform doctor to change the other treatment modalities. Now, let's show you the procedures of fiducial and synchrony tracking. A light-emitting dial vest was worn on patient, and the dials on the top were tracked by an optical camera. The breathing pattern of patient was then tracked in real time according to the chest wall position. 15 orthogonal X-ray pair images were acquired in different phases of breathing cycle, and fiducial position were tracked on each imaging pair. As a result, a predictive correlation model was then created between target position and breathing pattern according to fiducials and LED markers position. The target beam was then adjusted by robotic arm for target movement based on this correlation model, as shown in this movie. At last, the tumor movement would seem to be ceased, and the radiation beam delivery could be synchronized with the movement of tumor. This is the movie of showing why the traditional radiotherapy would give more radiation to healthy tissues in comparing with CyberKnife synchrony tracking treatment. Let's go to the dose results and comparison. I will show you the dose results of CyberKnife and its comparison with tomotherapy in case 2 by using the same planning CT and prescription. For the organ at risk dose, except D-mean of contralateral breast, D-max or D-mean of ipsilateral lung, right lung, heart, and spinal cord in CyberKnife were far lower than in tomotherapy. For example, for ipsilateral lung in CyberKnife plan, there was no V20, and V5 was only 1.8% in comparing with WIB-20 1.2%, and WIB-5 7.8% in tomotherapy. Moreover, for right lung, the Dmax in 7-Life was 4 gray in comparing with 7.3 gray in tomotherapy. Besides, the D-mean of heart in 7-Life plan was only 0.6 gray in comparing with 2.2 gray in tomotherapy. The conformity index in 7-Life plan was slightly better than tomotherapy. This was due to the hardest dose constraint requested by doctor for the heart. He wanted the Dmax dose of heart lower than 10 gray, and the D-mean of heart is less than 0.6 gray. As a result, this caused the target dose slightly spreading sideways along the target, and was therefore compromised some of the conformity of target. However, the treatment time in 7-Life plan was 47 minutes, which was far more than 8 minutes in tomotherapy. In this picture, it shows the dose distribution and beam path of 7-Life. This is the dose distribution of 7-Life pen versus tomotherapy pen. The light blue area is WIB-20, and the light green area is WIB-5. Let's go to the discussion. The 7-Life offers advantages of external beam radiation. The dose profile is comparable to radiotherapy, and it can have an excellent dose reduction for re-irradiated organs for local recurrence breast cancer. The target conformity is better than other external beam radiation therapy because of its non-coplanar treatment delivery. Moreover, high accuracy of treatment delivery by using synchrony respiratory tracking can reduce target and treatment uncertainty, which could allow for high-dose radiotherapy with fewer treatment fractions. However, there would be a trade-off for the advantages above. First of all, the treatment time of 7-Life is around 30 to 50 minutes, which is far longer than the other external beam radiation treatments, which is ranging from 10 to 15 minutes. Besides, it is needed to wait 1.5 to 2 weeks for tissue recovery and fiducial settlement after fiducial implant, before we could perform the treatment planning. As a result, it needs to take 2.5 to 3 weeks preparation time before starting 7-Life treatment. For future perspective, apart from the local recurrence breast cancer, I suggested that we could also use 7-Life for hypofractionated partial breast irradiation for early-stage breast cancer after lumpectomy, instead of using external beam radiation or radiotherapy. It is because 7-Life could reduce target and treatment uncertainty and allow for treatment intensification by using synchrony respiratory tracking. Moreover, its rapid dose fall-off could mimic high-dose radiotherapy to protect neighbor organs from unnecessary radiation. So, it is the best candidate for the hypofractionated partial breast irradiation for early-stage breast cancer. Furthermore, during lumpectomy, surgical clips will be placed by surgeons around the excision site to indicate the lumpectomy region for further treatment. I wonder if we could suggest surgeons to insert fiducials instead of surgical clips during lumpectomy. This could not only serve the purpose of marking up lumpectomy site, but also serve the purpose of fiducial-based tracking in 7-Life. Of course, it needs a consensus and cooperation between surgeons and oncologists. On the other hand, the principle of surgical clips and fiducial placement in 7-Life are different. Therefore, surgeons will need to take time to learn and follow the 7-Life fiducial placement rules. So, is there any easy way for fiducial placement of 7-Life and also ensure the placement accuracy? In this picture, you can see this is a commercial available 3D implantable markers with bioacceptable frame for lumpectomy surgical clips placement. The markers are placed in a fixed dimension inside the frame. Therefore, if we could cooperate with the markers company to tailor-make the markers that fit for CyberKnife fiducial placement rules, it could provide an efficient and accurate rate of fiducial placement in lumpectomy, which could serve both purpose of surgical clips and fiducial for CyberKnife. Here I come to a conclusion. CyberKnife is a non-invasive radiation therapy technique for local recurrence breast cancer. The high accuracy in target tracking allows high-dose treatment with few infections. Moreover, the characteristic of non-coplanar radiotherapy can provide an excellent dose conformity and rapid dose fall-off, which can greatly reduce the dose for the irradiated organs. It integrates all the advantages of other radiotherapy modalities for local recurrence breast cancer. And a future exploration could be done on the feasibility of using 3D implantable markers with bioabsorbable frame for CyberKnife fiducial implant during lumpectomy for early stage breast cancer. And that's the end of our presentation. Thank you very much.
Okay. Okay, let's begin our Q&A section. Since Mr. Yun is not available for the Q&A session, if there is any question for him, then we'll pass the questions to him and reply via email later on.
So, if any questions from our panelists?
I have questions.
Yes, Mr. Locke?
Mr. Locke. Yeah, I'm confused now. I hear for breast exam breast. How you can share for your experience from in your hospital? For example, breast. We want to diagnosis for breast. The first we choose memo. How we use memo digital. How we use ultrasound. When you use memo and ultrasound, when you use MRI, memo, breast CT, breast MRI. Because now I'm worried. I don't know when we choose. I think the first we use mammography and ultrasound. Okay, first step, and the next step, how we choose how we choose breast MRI or breast CT, or we choose both. You can share your experience from in your hospital.
Okay. I think Mr. Locke, how we choose the breast
image, MRI or CT.
Yes. So Ms. Ho.
Yes, maybe I try to answer this question. Since it always depends on the doctor, for my experience, if the patient is more invasive, I think at first the patient will go to the website. If the patient is more invasive, the doctor will be request for MRI. In my hospital, we are not very open to do the breast CT. So this is my answer.
We screening the first. We screening the memo and ultrasound. The first screening. After that, in a breast doctor choose MRI or CT. How about in yours?
They choose after they doing the mammography, screening or routine mammography. They usually do the breast MRI rather than CT.
The first choose MRI. Yeah.
Really.
Okay. Thank you.
Thank you. Thank you, Mr. Locke. Is any other question from our panelists?
Hello.
Yeah, hello.
Good afternoon. In Macau, how many percentage could we find malignant breast cancer by using MRI or nuclear medicine?
Sorry, can you pardon your question?
Yeah. At Macau, how many percentage could we find malignant cancer by using MRI or nuclear medicine at your hospital?
Okay, so
how many percentage could we find by using MRI or nuclear medicine?
Okay. MRI. So can Cecilia help us to answer the question? Using how many percentage of the patient finding?
Yes, very roughly is okay.
Yeah, finding malignancy using MRI or nuclear medicine.
I think in a hospital I don't know how many person. I think statistically, I encounter one malignant MRI breast. One person with malignant lesion will perform MRI every day. So I think 30% per month.
Yeah. Okay, it's okay because in Myanmar, very rare case for breast MRI and nuclear medicine. That's why I would like to know about that.
Okay,
some
supplementary in our hospital, we not yet have the nuclear medicine. So in our routine work, we do the patient screening in the mammography. If there is divided into several classes in Iraq, so which may be free, I'm not very sure, then they will go to the MRI. So in the MRI patient, many of them are malignancy because they are already doing ultrasound scanning or mammography already. So they will send to MRI for further diagnosis after they get lesion in mammography first. So MRI is not
same as Myanmar. I see. Thank you very much. Same as Myanmar.
Thank you. Yeah,
Kobe.
Yes.
Can I ask a question to Kobe?
Yes, of course.
Okay. How about CEM, contrast enhanced digital memo? Do you all do in your hospital?
Actually, we are not doing the CEM, the contrast mammography in our hospital. So I'm lack of that kind of experience.
Okay.
Yes.
Jalawan very experienced, a long time experience your mammography. I think you Jalawan share something for everybody.
Actually, I don't do memo. I do a lot of basic CT, but so long I don't do memo, but I learned a lot of memo because my students are system applicationists on memo. So down here, some hospital did contrast enhanced after they do biopsy or memo patient. So some of the hospital actually is like almost a routine. They have a standard protocols. I think that's all I know.
Okay, thank you, Ms. Chen. Is there any other questions from the panelists? Okay, and I want to ask a question for Mr. Chen from Hong Kong, Gavin. Hello, I see you put the fiduciary marker for the patient for the cyberknife treatment. So I think the fiduciary marker won't be taken out, right? So will the marker affect the MRI imaging further when the patient wants to do the follow-up? Or if the patient is that unlucky that get the recurrence again, so will we put the new fiduciary marker for the patient for the another cyberknife treatment or using the old one? Yes.
Well, that's a good question. The first one, first of all, if unfortunately, if the patient have a local recurrence, we could use the same markers maybe for the patients, because before we determine how can we use the old markers, we will perform a CT scan, and then doctors will see if the lesions is originally beside the or in old lesion or have a new one. So the doctor will design the lesion first, and then we will check whether the marker is suitable for CyberKnife or not. And for your second question, for the you mean the MR imaging, if there's a local recurrence or after the checking, or is it right? Is it the markers affect the
artifact generated by the fiducial marker?
Oh, yeah. Absolutely, because the markers will absolutely generate some artifacts in MR scanning. But the fiducial that we insert in the patient, the fat life fiducial, the company, the fiducial company claim that it is will produce less artifacts than the older one, because the older one, the older fiducials is more, the size is more larger, and the artifact is it's much more. So I think it will affect the diagnosis, or maybe cause the quality of image is not very well. But I think it's have no greater effect on the imaging, I think, in comparing with the older fiducials.
Mr. Chen, thank you for your answer.
I also have a question for Mr. Chang. Since the satellite treatment is much longer, the treatment time is much longer than the traditional RT. Have you encountered any patient move in between the treatment which affects the efficiency of the treatment?
Well, yeah, we have experienced some patient movement, and during the treatment, we can on-site check the movement of the patient. If the patient move, we will ask them to take a rest, and then we try again. But before, and in the presentation, you can see before the actual treatment, we will conduct a trial tracking for the patient. So in a trial, we will make sure the patient can lie on the couch more steady enough for maybe 30 or to 15 minutes according to the treatment time, to make sure the patient can tolerate the treatment time. So you are right. We do come across that problem, but after we introduce a trial tracking for the patient, the problems is greatly reduced already. Thank you.
Thank you.
I have a question for Ms. Low, Natalie. So in the first CT, I see a presentation. Do we do the CT in the plane scan, or we need a contrast? And I see from your presentation that you said the machine is doing the filter back projection. So if there is any other advanced machine that we can use the iterative reconstruction, do you think we can further improve the image quality or lower the radiation dose?
The first question is about the contrast medium. So I think it is depends on what is your primary aim for your breast CT examination. If we are doing the breast CT imaging because of screening for those patients who are afraid of pain for the mammogram, then I think plane scan can be the first step first. But if we want a further diagnostic performance on the breast imaging, then we can do contrast medium, like the contrast medium is those one we use in normal CT scan. And for the second question, because now here until recently, commercially running CT is using the filter back projection. So I think it's somehow now at this moment is lack of large population experience to see if we can change the reconstruction on IR. But if we theoretically, IR can help to improve image quality well, but we should think about the noise pattern if we change the reconstruction, and also think about the time that which the IR will need more time for the reconstruction process during the examination.
Okay, thank you, Ms. Low. And we got some questions from the Q&A box. So the first question is come to Cecilia. So the question is about that if the patient have the cardiac pacemaker and do the MRI or mammography, will it cause the malfunction, or how to sorry, it's not this one. How about the set band, the fat saturation in MRI with the patient with pacemaker? Cecilia. The fat saturation with pacemaker in MRI.
Okay. I have to say that I'm sorry that I still haven't encountered with any patients doing breast MRI with pacemaker. But as pacemaker has so many metals and wires inside the body, which would affect the MR image. I guess that with a good parameter of fat saturation technique and maybe just add a saturation band to the position of the pacemaker is located, will just slightly improve the MR image. But please beware that if you are adding the saturation band may affect the time to the dynamic scan. It may affect which means it takes more time for each scan. So it is apple and orange. It really depends on the diagnostic value you would like to achieve.
Okay, thank you.
I think there is another question in the Q&A box asking Ms. Ho, if the patient has cardiac pacemaker and will undergo the mammography, will it cause malfunction of the implant pacemaker?
I think in my opinion, the possibility for that the mammography will cause any malfunction of the pacemaker is very low. In my hospital, just no case was reported that the patient with pacemaker who are undergo the mammography has caused any damage or any other things. I think one more important thing is that we just be careful when you do the compression, not to damage the lead or the pacemaker itself when we're doing the mammography or cause any discomfort of the patient.
Thank you. And I also have a question to ask Ms. Ho. Is there any disadvantage of 3D mammogram? Do you think that 3D mammogram will totally replace the traditional 2D mammography?
I think it may not replace the 2D mammography because since the 3D is acquiring several images, then so that's why it can enhance the spatial resolution. When we combine those images to get a 2D image, this 2D image is a little bit blurry than the true one. So I think the 3D one cannot replace the traditional 2D mammogram.
Thank you.
So, and I think we have our last question for from the Q&A box for Cecilia also. So the question is about that, what's the temporal resolution for your dynamic contrast sequencing in your MRI scan, and how many phases that you do currently in your sequencing? Cecilia?
So in my hospital, we do 9 phases. Each phase is around 50 seconds, I think.
Okay, thank you. Thank you for your answer. And so I think it's the end of the Q&A section.
Okay, thank you, Mr. Au and Ms. Maggie. So now, let's welcome the General Secretary of Asia CPD, Ms. Peachy Luna, to announce the next CPD. Thank you, Ms. Luna.
Yes, hello everyone. Yes, hello everyone. Hello to the more than 1,500 participants of the Asia CPD hosted by the MRTA. So we would like to invite everyone again to please join the next Asia CPD. We'll be having two this coming month of October. One is to be hosted by the India Society of Radiographers and Technologists. That will be happening on October 16. And before the month ends, we have the Singapore Society of Radiographers to be hosting the next Asia CPD on October 29. So we hope that everybody would again support the next Asia CPD program. Thank you. Thank you, Cora.
Thank you, Peachy. Thank you, Peachy. Thank you, MRTA.
Okay, thank you. So thank you, Ms. Peachy Luna, and all of you. Since the scientific meeting is about to end, let's welcome the President of MRTA, Mr. Kuok, and the Chairman of MRTA, Mr. Dennis Yuti, to give us a conclusion.
Okay, thank you, Cora. Before we ending this session, I want to invite Mr. Kumar from India, President Radiologic, to talk something about the next CPD in October. Mr. Kumar, your mic is
Hello.
Hello.
Hello. Namaste. Very good afternoon, sir. Very good afternoon, panelists, presidents, and other members of Asian Community Radiographers, and warm greetings from Indian Society of Radiographers and Technologists, ISRT India. I first of all congratulate all the presenters today. They did the job very well. All the MRI, CT, all the topics they covered very well. Thank you for enlightening us with the different modalities of breast imaging. And thank you for organizing team by MRTA for inviting us to be a panelist in this occasion. Thank you, sir. And we are happy to announce that with the permission of the panelists and the presidents of Asian communities, this next CPD we are planning to host on 16th of October. The theme and the other details will be announced soon. And thank you all for guiding us to make this next program a successful one. Thank you and welcoming you all to take participation in the next CPD hosted by our ISRT. Thank you all. Welcoming.
Okay, thank you. Thank you, Mr. Kumar. And the next, the Singapore President, talk something about Dennis. Dennis, maybe your mic is mute here.
Yes, thank you very much,
Thank you
President
all
Fernando.
of you to join this meeting today. So I hope you enjoy and see you all next time. Thank you.
Dennis, please again.
Okay, thank you very much. Good afternoon to everybody, and thank you to MRTA for the very informative session today. I really learned a lot from all of our knowledgeable speakers this morning. So I just want to quickly share some details about the upcoming CPD Asia talk in October. So the Singapore Society of Radiographers will be organizing the session on the 29th of October. So that's the last Saturday in October. We will have two speakers who will be sharing about how we improved our workflows in our respective emergency departments. So we'll talk about how we managed to modify some of the radiology referrals, and also how we leverage on new IT systems to improve our workflow and efficiency in the emergency department. So please look out on our Facebook page for more updates, including the timing and the activated registration links. So I look forward to seeing everyone then.
Okay, back to you, President Fernando. Thank you.
Thank you, Denise. So we'll be ending. So thank you all of you to support Macau Association. So I hope you see you in next year in Macau. But I don't know the pandemic will be finished or not. But the Singapore now is good. I hope to go to there. But before I go to there, I will see you all. Remember on the last December of this year, I will share the screen. The RSRIT will be in December 15 to 17 in Bangkok. So I hope to see you all in Bangkok. Thank you. Okay, thank you, everyone. Thank you.
Thank you, sir. Thank you.
Thank you. Bye.
See you in
you.
December. Hello, Mr. Banan. Long time no see. How are you? Okay. Okay. Thank you, everyone. Thank you.
Thank you.
Congratulations, everyone.
Recording stopped.